Childhood Asthma by Caitlin Crick. The definition of asthma. Asthma is a chronic inflammatory disorder of the airways. Many cells and cellular elements play a role. Susceptible individuals experience recurrent episodes of coughing, especially at night and in the early morning, wheezing, breathlessness, and or chest tightness. Episodes usually associated with the airflow obstruction is often reversible either spontaneously or with treatment. Inflammation leads to airway hyperresponsiveness and airway obstruction, which are all clinical symptoms of asthma. An estimated 300 million people worldwide suffer from asthma, with 250,000 annual deaths attributed to the disease. Asthma is the most common chronic disease among children worldwide. And most asthma-related deaths occur in low and lower middle income countries. This is a proportion of population percentage on the deaths caused by asthma. The red is a greater than or equal to 10.1%, orange is 7.6 to 10%, yellow is 5.1 to 7.5%, green is 2.5 to 5%, blue is 0 to 2.5%, and the white means that there was no standardized data available. Some inducers, such as allergens, chemical sensitizers, air pollutants, and virus infections, lead to inflammation, which again lead to airway hyperresponsiveness and airflow limitation. Some symptoms of airflow limitation are coughing, wheezing, chest tightness, and dyspnea. Some triggers that trigger airflow limitation from airway hyperresponsiveness are allergens, exercise, cold air, and SO2 particulates. Causes of asthma 1 interplays between the host factors, which is particularly genetics, environmental exposures. Exposures occur at a crucial time in the development of the immune system. Definitive cause of the inflammatory process leading to asthma hasn't yet been established. The environment, allergens, infections, microbes, pollutants, stress. Biological and genetic risk, immune, lung, repair. They both have age in common. The innate and adaptive immune development, which is a TOPI. Lower airways injury, like respiratory viral infections, aeroallergens, ETS, pollutants, and toxins. Aberrant repair, persistent inflammation, AHR, remodeling, and airways growth and differentiation all lead to asthma. Causes of asthma 2, the environmental factors. 2 major factors for development, persistence, possibly severity of asthma. One's airborne allergens, especially sensitization, exposure to house dust mites, and viral respiratory infections, including RSV and rhinovirus. Other environmental factors under study is tobacco smoke, air pollution, such as ozone and particulate matter, and a diet, such as obesity, low intake of antioxidants, and or omega-3 fatty acids, which we've all come to know as the American diet. Pathophysiology is airflow limitation caused by inflammation. Bronchoconstriction is a bronchial SM contraction. It's the response to exposure to a variety of stimuli. Stimuli can be allergens or irritants, exercise, etc. It quickly narrows the airways, especially when you exhale. Airway hyperresponsiveness is also called twitchy lungs. It's basically an exaggerated bronchoconstrictor response. And airway edema is more persistent, progressive inflammation. Edema, mucus hypersecretion, insuppated mucus plugs. Think of asthma when you hear wheezing, which is a high-pitched whistling sound when you exhale. Lack of wheezing in normal chest examination do not include asthma. History of any of the following: cough, worse particularly at night, recurrent wheezing, recurrent difficulty in breathing, and recurrent chest tightness. Especially if these symptoms occur or worsen with exercise, viral infections, inhalant allergens such as animals with fur, hair, house dust mites, mold, pollen. Irritants such as tobacco or wood smoke and airborne chemicals. Changes in weather, strong emotional expressions such as laughing, crying, getting angry, stress, menstrual cycles, and awakening at night because you could not stay asleep. Spirometry. The 2007 guidelines recommend objective measurement of pulmonary function as part of the initial evaluation. Most children older than 6 or 7 years are capable of performing a forced expiratory maneuver if coached by an experienced technician. Some centers can test children as young as 5. A spirometry should be performed before and after administration of a short-acting bronchodilator. Spirometry results may be normal, especially in children with mild asthma. FEV1 that increases by 12% or more following the administration of bronchodilators indicates reversible airway obstruction, even if the baseline FEV1 is normal. This is a diagnostic flowchart for asthma in clinical practices. We'll just focus on the yes part right now. So a patient with respiratory symptoms, you can ask, are the symptoms typical of asthma? Yes, then you go into a detailed history and examination for asthma. Then is the history examination support the asthma diagnosis? Yes. Then you perform a spirometry PEF with reversibility test. And if the results support your asthma diagnosis, you treat that said patient for asthma. Now, if the symptoms are not typical of asthma, you can dive into a further history and test for alternative diagnosis. Alternative diagnosis confirmed. If not, then you can go into a detailed history and examination for the asthma. And if it does support the asthma diagnosis, then you go through the whole yes again. But if the alternative diagnosis is confirmed, then you can treat for alternative diagnosis. If the alternative diagnosis is not confirmed, you can repeat on another occasion or arrange other tests. If that confirms the asthma diagnosis, then you can perform the spirometry PEF with a reversibility test. If it doesn't, then you consider trial and treatment for most likely diagnosis or refer for further investigations. Pharmacotherapy for asthma. 2 main broad classes of drugs: bronchodilators, bronchospasm, beta agonists, which are fast-acting versus long-acting, SABA versus LABA. Others, epinephrine, theophylline. Steroids, which is inflammation, edema. You can have oral or IV, which is systemic, versus inhaled, which is local. The third group is leukotriene modulators, mast cells, which are TOPI, immune system, LTRA, which is leukotriene receptor antagonists. This is a written asthma action plan, and it should include the patient's usual asthma medications, when and how to increase medications and start OCS, and how to access medical care if the symptoms fail to respond to said medications. A differential diagnosis: early infancy, birth to 6 months, aspiration symptoms such as gastroreflux, bronchiolitis, foreign body inhalation, which is very rare, infancy to early childhood, which is 6 months to 3 years, bronchiolitis, transient wheezing of childhood, TWC, foreign body inhalation, CHD, and TB, late childhood, which is older than 3 years, asthma, transient wheezing of childhood, TWC, and can also lead to congenital heart disease. The classification of asthma severity. This is for 0 to 4-year-old children. Your symptoms, if you have them less than 2 days a week, it is intermittent severity. If you have them more than 2 days a week, but not daily, it is mild severity. Daily, it is moderate, and throughout the day, it's severe. Night awakenings, if you have 0, it's intermittent. 1 to 2 a month, it's mild. 3 to 4 a month, it's moderate. Greater than 1 time a week, it is severe. SABA use, less than 2 days a week, it's intermittent. More than 2 days a week, but not daily, it is mild. Daily is moderate, and several times per day is severe. Interference with your normal activities, none, it's intermittent. Minor limitations, mild. Some limitation, moderate. And if you are extremely limited in your normal daily activities, it is severe. Now, ventilation is divided into 2 different groups, such as non-invasive ventilation and invasive ventilation. Non-invasive ventilation. Non-invasive positive pressure ventilation should be tried prior to conventional ventilation. And invasive ventilation is volume control mode. AR approximately half of the normal for age. The IE ratio of 1 to 3, PEEP of 0 to 2 centimeters of H2O. In infants, pressure control ventilation with PIP should be adjusted. There's also helium oxygen therapy. For children who are not improving with the conventional therapy, or children who are receiving high pressure mechanical ventilatory support, Helix might be a reasonable adjunctive therapy for them. And that's all. Thank you.